Good afternoon, and thank you for joining us. Welcome to today's webinar, Food is Medicine, Reducing Barriers to Accessing Healthy Food in Vulnerable Communities. This webinar is part of our two-part series, Reducing Food Insecurity and Obesity through the Healthy Montgomery Transforming Communities Initiative. This is a new webinar series that will highlight real-world examples of how a collective impact approach is improving community health in Montgomery County, Maryland. My name is Evelyn Kelly, and I represent the Institute for Public Health Innovation, also known as IPHI. IPHI is the official public health institute for DC, Maryland, and Virginia, and engages in partnership-based solutions to public health challenges and the promotion of health equity. Before we dive into the content and introduce our presenters, we have a couple of housekeeping items. This webinar is being recorded and will be available to watch again at a later date. We want to hear from you, so feel free to ask questions. If you are using the Zoom web app, you will see a Q&A icon at the bottom of your screen. Please type your questions there. If you are using the Zoom web browser, you will not see this function. Instead, please click the chat icon at the bottom of your screen and we will forward your questions to the correct panelist. In order to ensure that all participants are able to hear clearly, all microphones will be muted. If you are having a hard time hearing the webinar at any point, please let us know via the chat function at the bottom of your screen. We also encourage you to dial in with your phone if you're having a hard time hearing through your computer. We will answer questions for each of the presenters at the end of the webinar. We encourage you to submit your questions as they arise. We thought it would be helpful to provide some context regarding our focus community. Montgomery County is a large county of over 500 square miles and over 1 million residents. Bordered by Washington, D.C., suburban Virginia, and other Maryland counties, the county ranks well above the national average for median income, and overall poverty is less than half of the state's rate of 15.4%. However, Montgomery County is characterized by profound health and wealth inequities, and areas of poverty are interspersed throughout the county. Persistent health disparities exist among people of color, particularly African Americans and Latinos. These include significant disparities related to obesity, chronic disease, smoking, eating fruits and vegetables, and engaging in physical activity. Through the Healthy Montgomery Transforming Communities Initiative, we have created partnerships to work within key communities to effectively implement policy, systems, and environmental change strategies to reduce health inequities. Now I'd like to provide an overview of Healthy Montgomery and the Transforming Communities Initiative, also known as TCI. Healthy Montgomery is the official community health improvement planning process for Montgomery County, Maryland. IPHI has worked closely with the county's Department of Health and Human Services on this effort since 2010. Healthy Montgomery is also funded by the 4 county hospital systems, including Adventist Healthcare, MedStar Montgomery, Holy Cross Health, and Suburban. You may visit the Healthy Montgomery website for additional information. We are experiencing some technical difficulties at this time, but we're working on getting them resolved and are going to keep the webinar moving forward. You may experience a slight delay in the actual PowerPoint slide. So to provide some context, the Healthy Montgomery TCI is a collaborative partnership comprised of Holy Cross Health, IPHI, the Montgomery County Department of Health and Human Services, the Eat Well Be Active Partnership, and numerous other government and community partners that aim to address obesity and tobacco-free living in the county and is funded by Trinity Health. The Healthy Montgomery, TCI, seeks to promote healthy behaviors and prevent chronic disease by influencing policy, systems, and environmental change strategies that influence those behaviors. The Healthy Montgomery, TCI, focuses on 5 strategies related to school wellness, tobacco prevention, community food access, safe routes to school, and early child care nutrition standards. Today's webinar is part of a 2-part series highlighting efforts that are addressing food insecurity and obesity through the TCI. So let's get started. We will hear from 2 speakers today, including, we begin with Ben Fulgencio Turner, Director of Coverage and Connections at the Primary Care Coalition of Montgomery County. Then we will hear from Lucia Segara, who is Director of Health Programs with Community Health and Empowerment through Education and Research, also known as CHEER. Each speaker bio is included in the slides and on our website. I will now turn it over to Ben to get us started.
Good afternoon, everyone. This is Ben Fulgencio Turner. I work at the Primary Care Coalition of Montgomery County. So we're also known as PCC. So just waiting for a second to catch up the slides. So the PCC has a 25-year history working to improve access to healthcare, quality of healthcare services, and strengthen local systems to improve health in our community. We are excited to be a part of new partnerships like Food is Medicine and the Transforming Communities Initiative that bring together innovative practices and a wide range of organizations from local government, healthcare providers, community organizations, and social service providers, all committed to a shared vision of a diverse community in which all residents have the opportunity to achieve their highest level of health. Evelyn gave a little bit of the background on Montgomery County, Maryland. So as she mentioned, it's a suburb of Washington, D.C. with a little bit more than 1 million people and is an incredibly diverse county with growing diversity. It's a majority of people of color, 40% speaking a language other than English at home. And while the most common language other than English is Spanish, there are more than 80 languages spoken by a significant number of county residents. In addition to the incredible diversity in our community, as Evelyn mentioned, there's also growing poverty and disparities. Zip codes where the median income is below the self-sufficiency standard, meaning that more than half of residents earn less than the self-sufficiency standard, which is how much you would need to get by, one more. Oh, here we go. So in the red areas are the zip codes that show the where more than half of residents don't earn enough just to get by the self-sufficiency standard. The burden of poverty in Montgomery County is not evenly distributed. People of color and foreign-born residents are much more likely to live under the poverty level and in high poverty neighborhoods. The chart to the right shows that Black and Hispanic residents in Montgomery County have a poverty rate 3 times higher than non-Hispanic white residents, and Asian residents have a poverty rate twice as high. And the map to the right, there's another heat map. It should look pretty familiar since it shows a lot of the same concentrations, showing that people of color and immigrants are more likely to live in those areas of highest poverty. Because the bulk of our work at PCC is focused on safety net healthcare, we have been paying close attention to changes in the health coverage rate in Montgomery County. Since the implementation of the Affordable Care Act, or the ACA, began in 2014, the uninsured rate has declined significantly. It's down from over 11.5% to about 7% in 2017. There are still tens of thousands of remaining uninsured residents, but this is a large improvement. Unfortunately, despite these improvements, there are still disparities in coverage based on race and ethnicity. In this chart to the right, you can see that the blue bars are before the Affordable Care Act was implemented, and orange bars are after. So before the ACA was implemented, there were already very large disparities where people of color, Asian, Black or African Americans, and Hispanic or Latinos were much more likely to be uninsured than non-Hispanic white residents. But even after the Affordable Care Act, when we have made such big improvements in the uninsured rate for each of these groups, Asian residents are still more than 3 times as likely to be uninsured. African American residents are about 4 times more likely to be uninsured, and Hispanic or Latino residents are nearly 11 times more likely to be uninsured than non-Hispanic white residents. These disparities in coverage rates are mirrored by disparities in health risk factors. So African Americans, about 1/3 of African American residents in Montgomery County and 1/5 of Hispanic or Latinos are hypertensive or have high blood pressure. More than 2/3 of African American adults and 3/4 of Hispanic adults are either obese or overweight. And among teens, about 1/4 of African American teens and 30% of Hispanic teens are obese as teenagers. So this is a real problem. It shows that the populations growing most quickly in Montgomery County are also suffering the highest burden of risk factors for cardiometabolic conditions that drive a lot of the poor health and healthcare costs in Montgomery County. So this should be familiar to a lot of folks. You might have seen similar pictures to this, showing that the things that make us healthy are not just healthcare. That primary healthcare, especially preventive healthcare, is very important, but much more important than that are the environments that we're exposed to and the behaviors that we exhibit every day. So things like what we eat, our physical fitness, smoking, risky behaviors, all of that are much more important drivers. And as we look to address those long-term health outcomes and risk factors, we need to shift our thinking from just looking at healthcare services to looking at these systems, environment, and policies that can help drive improvements. One of these health factors that's most strongly aligned with the chronic risk factors is food access and nutrition. So in Montgomery County, there are over 70,000 residents who are food insecure. That means they do not have consistent access to safe, sufficient, and nutritious food. As you can see on the map to the right, the areas with the highest concentrations of food insecurity, this lines up with a lot of the other heat maps that we've seen, are also the areas with the highest concentrations of poverty and where the most low people of color and immigrants in Montgomery County live. The Montgomery County Food Council published the food security plan just a couple of years ago, looking in a really deep dive into the barriers to food access and strategies to help address them. Of course, some of these barriers should not be too surprising, that having low income would of course mean it's hard to have enough money to buy the food that you need. In addition, immigration status is a major driver of food insecurity. Recent immigrants face both administrative burdens to accessing benefits, like eligibility for programs based on status, as well as cultural and linguistic barriers. And because in Montgomery County, many families are mixed status, where some family members may be U.S. citizens, some may have a green card, some may have a temporary status, and some may have other, even more complex statuses, figuring out whether or not you are eligible for something and how to access this system is a significant challenge. And of course, compounding that are the language access issues and cultural issues, and cutting across all of these areas is transportation. Folks who are low income are much more likely to not have a car and have to rely on public transit systems. And people who are low income, people of color, and immigrants in Montgomery County tend to live in the densest areas and some of the areas that are cut off from public transit networks. So we already know that there's a significant population overlap. The folks that are targeted at highest risk for food insecurity and hunger in Montgomery County are also the folks who are most likely to be uninsured. Low income, people of color in the county, and recent immigrants in Montgomery County. And we also know that, so we know that we want to serve the same group of people, and we know that food insecurity and hunger directly causes poor health. So children are more likely to get sick if they are hungry and have trouble keeping up at school. Being food insecure, not knowing whether or not you're going to have enough food, causes stress, anxiety, and can lead to depression. It's harder to manage chronic diseases like diabetes or high blood pressure if you are food insecure and are not sure whether or not you're going to be able to afford everything that you want to put in your grocery basket. Children who are food insecure are more likely to develop pediatric asthma, and both adults and children are more likely to be obese or overweight if they are food insecure. So that last one might seem a little bit counterintuitive. Why would not having enough food cause you to be obese? You might expect hunger to cause malnutrition, stunted growth, and other bad outcomes, but why obesity? In fact, there's a pretty clear causal mechanism. I want to say straightforward, but this is actually a lot of factors driving into this. There's a cycle of food insecurity that lead both to higher risk factors and changes in behavior that increase these risk factors. And for anyone that wants to take time and study this infographic a little bit more, this is from a Health Affairs article, and I'd be happy to send around the links to folks. So some of the risk factors caused by food insecurity, as we mentioned before, is stress and anxiety. And as anyone who's ever tried to lose weight or avoid gaining weight when they're stressed out, it is not helpful to be stressed or anxious. When you are food insecure and you're not sure whether you're going to have enough money to buy the food that you need, you're more likely to purchase cheaper foods that may be less nutritious, even if they're more filling. The costs of food will lead you to reduce the variety in diet, again, compounding these issues of having low nutritional value, but more filling and calorically impactful meals. And finally, because sometimes you may have enough money and other times you do not. People who are food insecure tend to skip meals when there are no resources, and then whenever they do have access to food, there's a strong compulsion to binge eat, to eat what food is available when it is available. And so all of these factors and behaviors compound, leading food insecurity and hunger to drive a higher risk for obesity. So as a part of the Transforming Communities Initiative, the Food as Medicine program is focused on making policy, system, and environmental changes. And so our program model emerged as a way to address two overlapping concerns: growing health risk factors for cardiometabolic conditions and food insecurity in Montgomery County, both within this same population of low-income, people of color, and immigrants in Montgomery County. So our goal is to create a permanent pathway that effectively links the safety net healthcare programs in Montgomery County with food assistance and nutrition education services, aiming to reduce the risk factors that drive cardiometabolic conditions like diabetes, hypertension, and other related conditions. So a little bit on the safety net healthcare systems in Montgomery County. For this program, we focused in on two main programs. The Montgomery Cares is a program that's 20 years old in Montgomery County. It serves over 24,000 uninsured low-income adults, and Care for Kids serves over 6,000 uninsured low-income children. These programs have tremendous reach to the highest risk group, serving low-income residents who remain uninsured in Montgomery County. And our partnerships with safety net clinics, hospitals, and school-based health centers really extends the risk beyond just our walls to a much larger group. And to start off, we're implementing the programs in the TCI targeted areas, which calling back to some of those heat maps I showed earlier, these are areas that are at the epicenter of highest density of low income and highest risk factors. In order to screen for food insecurity and link patients to services, we rely on the Hunger Vital Sign. This is a 2-question screening tool. It's adapted from a much larger 10-question screening tool, but asking the 2-question is sufficient to understand whether or not someone is food insecure. So the 2 questions are: in the past 12 months, were you worried that food would run out without money to buy more? And in the past 12 months, did your food run out and you didn't have money to buy more? Answering yes to either of these questions will qualify you as food insecure, and our clinic teams would then ask whether or not you agree to get follow-up from community health workers to help connect you to resources. So our community-based follow-up is really part of the heart of our program. After patients have been screened as food insecure and referred to food assistance, community health workers, or CHWs, follow up to connect them with resources. CHWs are recruited from the populations that they serve and provide culturally competent and linguistically appropriate follow-up to effectively link them to resources. My colleague Lucia will be talking more about the nature of CHW's work, its challenges and best practices to making it effective. But we do know, and it's important to emphasize, that if we do not provide for follow-up, Referrals, especially referrals to social services, simply do not work. Just giving people a piece of paper does not connect them to resources. It does not help them to understand how what receiving those services would look like, or help them to get over the barriers that they might face in order to access those resources. In the first year of the program, the Food as Medicine program has made steady progress in implementing a routine referral and follow-up system. We're on track to screen an annual total of 1,500 families, with goals to expand into the much larger safety net population in Montgomery County of 24,000 adults and 6,000 children, and the opportunity to continue to grow beyond that to the tens of thousands of Medicaid patients and privately insured patients who also face risk factors in Montgomery County. The screening and follow-up has been effective. Roughly 75% of patients that receive follow-up are successfully connected to food assistance resources. And finally, when we look at outcomes in terms of changing behaviors and in terms of improving the health outcomes of participants and reducing their risk factors, we found a lot of success with the focused intervention programs that identify those at highest risk and provide intensive services. And my colleague Lucia will be speaking a lot more on that in just a minute. And so with that, I will be I'm going to be handing it off to Lucia Segarra. She's the Director of Health Programs at CHEER, Community Health Empowerment Through Education and Research.
Thank you, Ben. Good afternoon, everybody. Let me tell you a little bit about CHEER first. If we zoom in Montgomery County in the areas of Long Branch and Tacoma Park, you'll find us. Our mission is to give people the knowledge and ability to create healthy, thriving communities and neighborhoods. We have 4 areas where we have programs. One is health, housing, community development, and youth development. So here's a list of our programs. We offer enrollment in health insurance through the Affordable Care Act. We conduct health outreach in local supermarkets, test center, schools, and churches. We also have leadership development in schools and the community. We have a program called Ask the Doctor, which is a monthly event where we have a doctor come into our office for free and folks can ask any questions they have. And the program I'm here to talk to you about is the Long Branch Healthy Food Access Program. So our program is for folks with diabetes type 2 in our, sorry, I skipped one slide. So let me talk to you about our amazing partners. Our partners are the Primary Care Coalition, Mana Food Center, Capital Area Food Bank, Crossroads Farmer Market, Clifton Park Baptist Church, Mobile Medical Care, and we're very grateful to have Healthcare Initiative Foundation, Adventist Healthcare, and the Healthy Montgomery Transforming Communities Initiative as funders. I have to say that Healthcare Initiative and Adventist Healthcare are also very involved partners in this. To talk to you a little bit about our program serves people with diabetes in our area. The zip codes are 20901, 20902, 20903, 20904, 20910, and 20912. It's for low-income qualified individuals, and they receive 12 weeks of free fruits and vegetables. The only requirement that we have for them is for them to participate in one activity a month to learn about healthy eating and healthy cooking. We have a team of 6 community health workers, and our main role is to conduct intake interviews to assess the individual situation of the participant, to connect participants to food resources. Within our program, they send referrals to Mana, Hungry Harvest. They connect them to Hungry Harvest to receive their boxes. They receive food from Capital Area Food Bank and Crossroads Farmers Market. They were receiving fresh checks. They also connect them to nutrition education and community resources. Our community health workers also motivate and provide personal support to our participants to make behavioral changes. Our goal in this program is to help our participants change their eating and shopping habits, as well as empowering them to take charge of their own health. And as Ben mentioned, that our community health workers are members of the community we serve, bridging cultural and linguistic barriers, and this helps us expand access to coverage and care, improving health care outcomes. Our program serves a very vulnerable population. we've seen that 85% of our participants primarily speak Spanish, suggesting that a large majority of them is Latino or Hispanic. And most of them are immigrant families. 35% speak English well or very well. 75% are over 45 years of age. 70% of participants are women. 90% of participants are overweight or obese. And this is the most surprising is that only 12% of participants are in the normal range of glycemic control. So let me talk to you about how we're measuring this. We collect the information from the providers, the A1C, which is the hemoglobin A1C, measures the average blood glucose levels over the past 3 months. This test measures the amount of hemoglobin with attached glucose in blood. So the normal will be below 5.7%. Between 5.7 to 6.4% will be pre-diabetic, and people with 6.5% or more will be diabetes, will have diabetes diagnosis. We are linking participants to services. We've seen that in our first year, we had a total of 1,224 boxes of food provided to our participants. And in terms of educational activities that we have offered, we have had 134 community members participated in an educational activity a year. And one of the most important things that we really want to stress is that food is changing health outcomes. We see that through food security declining from 74 to 54% in our second cohort. 40 to 50% of our participants are eating more fruits and vegetables, and 60% of those with fair or poor health improved in their self-reported health status. And this is basically a response to a question. In general, how would you rate your current health status? And the options are very good, good, fair, bad, very bad. And in terms of clinical outcomes, we've seen that 65% of participants lose weight. 79% of these lost an additional 3.8 pounds after the program ended. 75% of participants with out-of-control diabetes improved their blood glucose level. Our challenges were several, and we tried to summarize it as much as we could. I wanted to start with the first. The immigration policy climate brought a lot of fear to our community and made building trust with our community members very difficult. And as a result, we currently do not have any participants that are willing or were enrolled in SNAP. Isolation, this one is a twofold challenge. We have participants with do not want to share their diagnosis with anybody in their family, which causes isolation. And also the fact that most of our participants are immigrants. They're already dealing with isolation from the community and the culture as well. Mental health is another big one. And so research indicates that there is a link between diabetes and depression. So having diabetes increases the risk of getting depression. Here, we also see that immigrants experience high levels of stress during a short period of time, which also leads to depression and anxiety. Our food distribution logistics was also a challenge. The schedule of working families usually did not coincide with the food distribution times from area food banks, distributions at churches, so that was really hard for them. As Ben mentioned earlier, the lack of transportation was also very clear. Participants who usually take the bus were less likely to show up to events when it was snowing or raining. And we also saw that some households lacked the funds to spend in additional transportation to events and food distribution dates as well. One important one was that we realized that cultural assimilation is a huge challenge for our families. For example, meal planning is a new concept. Our participants are used to cooking every meal from scratch the same day, and most don't prefer heating up food. Some participants do not have calendars, which is really hard makes it really hard for them to track doctor's appointments. So they miss their doctor's appointments, they miss food distribution dates. And finally, women do most of the cooking. So if the husband is the one with diabetes, he depends on the wife to learn that he has diabetes so that she can relearn how to cook just for him. When she has to deal with cooking for picky eaters, perhaps increasing the difficulties for the household. And what did we learn? We learned that establishing personal relationships is very important, because this is what motivates behavioral changes. The CHW participant dynamic and relationship creates accountability and expectations on the participants. For example, we had one participant who told us, I had to eat the vegetables because the community health workers brought them to me. So there's accountability there, and we were very excited that these relationships were making a change. It is very crucial that we use a holistic approach when we deal with our community members. Our CHW really need to be sensitive to diverse challenges depending on the participants, what they may be facing at the time. One example here is one of my participants. He was dealing with bedbug infestation at home. So here I come trying to push fresh fruits and vegetables when he's freaking out and trying to move all his furniture out of the house and try to heat up his home so that he can get rid of the pest. So we had to work with him step by step, help him find volunteers to move his furniture, and then I could sit down calmly and talk about his diet. Everything has a learning curve, just like this program. And it takes a participant some time to learn pickup locations, dates, times when local food banks are open. And this has proven to be a challenge for a participant. Sometimes by the time the program is over, they're just then getting used to the program. We have to teach them step by step. Every participant is at a different stage in the process of change, and they all learn at a different pace. So we really can never expect abrupt changes. Another very interesting thing that we learned is how people communicated and how information was acquired. We found out that they usually get their information from social media. Everybody has Facebook. And then we found, of course, that phone numbers are not reliable. We never know if people are going to pick up the phone or not. But text messages and WhatsApp helped reach them. Sometimes people were not really well, some people had difficulties reading in Spanish. So a picture of the food that they were going to be receiving was an incentive for them to remember that they had to come pick up their food. We learned that scheduling events during nights and weekends when participants it was a time when participants were the most available. And I would just wanted to finish by saying that we really learned that the main thing that we learned was that we need to respect the participant. If we have an initiative in the community, we really need to find out who's ready to make the change and just not assume that everybody is. Thank you, and I will pass it on to Evelyn.
All right, thank you, Ben and Lucia. So just a reminder that we will be sharing the slides after today's webinar. At this point, we are ready to answer some of the questions and comments that have been streaming in during the presentation. For those of you who have not taken advantage of asking questions, we invite you to ask questions or make comments by typing in the chat box or Q&A box at the bottom of your screen. If we do not get to all the questions today, we will follow up with individual questions that were not addressed and post the answers online. So we do have a number of questions that come in, and the first question, I'll leave it to both of you. and that is, what measures of food insecurity do you use?
Sure. So I can field that one. So we've been using the Hunger Vital sign, which is the 2-question screener. Sometimes this question can be adjusted where people ask whether or not let me grab those exact questions for anyone who actually wants it. So they ask whether you have, in the last 12 months, been worried about not having enough food, or in the last 12 months, there's been a time where you did not have enough money to buy the food that you wanted. And some people adjust these to ask over the last 3 months or over the last 6 months to get a more precise or more to get a different type of range. But so what's important is just asking these questions consistently and building the confidence of community health workers and of clinic staff and administrative staff to be able to have these conversations about food with their clients.
All right. The next question is for Lucia. What is your process for people to become community health workers?
So we train them through the IPHI, Institute for Public Health and Innovation. We basically make an open call to everybody who's interested, and we take applications, and just check online on our website, communitycheer.org. We should be posting new job application posting soon, so we're looking forward to.
Do you usually have to recruit, or they come to you?
There has been some cases that people have come to us, but we're constantly looking forward to meeting people that may want to take that. So.
All right. I do have the next question is in regards to cooking instructions. Do the participants see a need for cooking instructions in this effort to help people eat more fresh fruits and vegetables?
That's a good question. So we've been playing with different strategies in terms of cooking instructions. And we've been using cooking recipes from the Maryland Extension Program. But we've noticed that our participants are not too keen of fresh salads. So we've been talking about replacing ingredients or eating less, because we're looking at more sustainable changes in behavior. And if we just tell somebody, you know, you have to change completely how you're handling your cooking, it's going to be more difficult for them to keep it for a longer period of time. So we're just telling them, yes, you can eat what you're eating, just eat less tortillas. Don't eat 3 sweetbreads in the morning, just eat half of one. So we go step by step, and that's when I refer to teaching step by step. You don't shoot for the 5K, you know, 1 mile at a time.
Okay. And I do have another question regarding SNAP. A participant did want to know, in terms of clarifying, did Lucia say that there are currently no participants who are receiving SNAP? How about WIC or senior benefits? Is this due to the recent public charge rule change?
So the public rule change is probably going to affect things even more, but what I'm presenting right now is from what we've had for the past year. We definitely have a lot of seniors that have benefits. WIC, we have a lot of moms that have WIC as well. And again, and this is information that we get after building trust with them, because this is not a questionnaire that we ask everybody. You know, do you have WIC? Sometimes people just decline to answer these questions. The trust and the fear is still there.
And just in case anyone is not too steeped in the food world jargon, so SNAP and WIC are both different types of programs for food assistance from the federal government, both commonly known as food stamps, where SNAP is for adults and WIC is for children. And I would add to that generally the population that we're working with is largely ineligible for SNAP, the adult program, due to their immigration status, that you have to have a green card with a certain number of years or U.S. citizenship in order to qualify for this program. And then for folks that aren't aware of the public charge rules, this is new rules coming down from the Trump administration that would consider whether or not your family is receiving federal benefits in the process of naturalization. So these rules have not been implemented yet, but they have been discussed very broadly in the immigrant community, and there's a lot of fear that this may cause a chilling effect where folks drop out of their benefit programs pull their kids off of Medicaid services, pull their kids out of food stamp programs because they want to make sure that they'll be able to naturalize. And so far, I would emphasize that these rules have not been implemented, and they are not retroactive. They're not back-looking. So if you're talking to folks, please do not encourage anyone to drop out of programs that they are eligible for. If you are eligible for services, you should continue to receive them, and just keep an ear to the ground for what these policy changes actually look like.
Yeah, that's a very good point, Ben. One of the other questions we had was in regards to sustainability. So Lucia, you showed some really great results that we're seeing from the participants in terms of health changes. What are the needs or plans for sustainability once participant cohorts conclude?
So, and this is a very good and important question. We are very interested in keeping our A1C levels low. So we are offering all our graduates to participate in our events after the program ends. And right now we're gearing towards having more capacity and be able to have a refrigerator, to have more food, to be able to provide food for folks that may have graduated from the program but still need a little bit more assistance. We still have a lot of our community health workers receiving text messages asking, can you help me? Where can I pick up more food? So we're still in constant contact with them, which is great. So we're always trying to figure out how we can help them. We don't just drop, they're graduated by, we're done with the program. They're still in touch with us. They get invited to all our Ask the Doctor events. So they still have that connection with the physician in case they cannot afford it. And we're also looking for those who express interest in continuing with our community, building a community. We're interested in building somewhat of a food club where community members are in charge of their own food distribution. We distribute food from the Capital Area Food Bank. So ideally, we would bring the food from the Capital Area Food Bank, and our community members would handle the distribution themselves. So that, you know, talking about sustainability, they will be able to maintain that system without us stepping in.
Yeah, we've had several questions about self-sufficiency. We have another question about how are you addressing self-sufficiency standards? The cost of living is higher in your county, and your standards are well above the federal poverty level.
Yes, so right now the programs that we're working at have the eligibility level for Montgomery Cares and Care for Kids are set to 250% of the federal poverty level. So that does not help the people who are not eligible, who out-earn food stamps or WIC programs, but it does kind of cover some of that gap, even though it's not all the way up to the self-sufficiency standard. And then we rely on the network of programs like MANA and the Capital Area Food Bank that also use self-sufficiency standards for a lot of their programming in terms of food access and distribution, so that we're able to bring it up higher, addressing the fact that the cost of living is so high in the county. Oh, and MANA is one of our core partners that is a community food access program that works throughout Montgomery County, recovering and distributing food for residents.
Yeah, in the county.
Yeah.
And they're looking also to open a new site in the east part of Montgomery
Yes.
County. So we're really excited that they are very involved in this community goal.
All right, I think we have time for another question. This is in regards to just overall program monitoring. So how is the program monitored?
So I can tell you that we have meetings with all the partners where everybody chimes in and what things we can do better. Everybody is open. It's an open flow where everybody makes suggestions. We look at results, and we're always striving for what's the best for our participants. We have weekly meetings with our community health workers where we concentrate on what are the issues with their participants, how we need to handle certain things. And I also do one-on-one with community health workers in case we need to talk more about particular cases. We are very grateful with Primary Care Coalition with Ben, because he's been helping us to do the overall evaluation. And I don't know if you have.
Yeah. So on the kind of colder side of program monitoring, just on the data piece. So we, because the Primary Care Coalition administers the electronic medical records for several of the clinics, including those participating in the program, and the administration process for the Care for Kids program. We have a lot of really rich data that we can work with for monitoring both program implementation and outcomes for all of our participating organizations. And we're able to merge that with the data collected by organizations like CHEER and MANA, who use other data systems to track individual resources. So we do monthly and quarterly reports where we aggregate and analyze this data.
And I'll have a final question in regards to expansion of program. I think ideally when we talk about policy systems and environmental changes, we want these changes to be institutionalized with the hope that they can continue and hopefully expand. So when we talk about expansion, what does that potentially look like for you all and for this program, and what would be helpful to move that forward?
So what's very exciting is that we recently are starting a new program expanding in East County, which I don't want to call back to the maps, but kind of moving east from that Long Branch area that continues to be an area of lower income and majority people of color. And so the business, Montgomery County Business Leaders Fighting Hunger is a coalition that came together and raised money to fight food insecurity in Montgomery County. And where the Food is Medicine program expanding to East County is the first grant of this, which is starting right now. We're just in the first month of it, looking to replicate a lot of the outstanding work that CHEER is doing in Long Branch. I would say that when we look at this work, the big challenge is what Lucia articulated so well, is that you need the personal relationships to be effective. It's not just about giving baskets of food to people or building a constant system of referral. You really need those on-the-ground workers who can assess where people are at, build a relationship and trust with them, and both encourage behavior change, help them get connected to resources in order for us to then continue to show what a big impact this has and expand out from there. Anything to add?
Yeah, I guess I would add that we also need commitment from the healthcare providers, because I think that has been one of the things, the biggest challenges for us is that if we get primary healthcare providers to really believe in this system, and then we will get tons of referrals. So we feel like, you know, building that relationship also with the providers is also key for the community health workers, that having that relationship, for them to see community health workers as a valuable piece of the puzzle of how we can produce these dramatic health outcomes. It's very important for programs like us, like ours, to be successful.
All right. Well, I think that is all the time that we have for our webinar today. We want to thank our presenters and thank you, our participants, for joining us. On this slide, please find links to more information about today's topic. Within the next week, please be on the lookout for a link to the recording of this webinar. We will also post it online on the Healthy Montgomery and IPHI websites, which are listed on the slide. Also, stay tuned for future Healthy Montgomery webinar series topics. On behalf of the Institute for Public Health Innovation, thank you for joining us and taking the time to participate in our webinar. Have a wonderful day.